Hello and welcome to By the Book, a podcast series from ASCO that features engaging conversations between editors and authors of the ASCO Educational Book. I'm Dr. Pedro Barata. I'm a medical oncologist at University Hospital Seidman Cancer Center and associate professor of medicine at Case Western Reserve University in Cleveland, Ohio. I'm also an associate editor of the ASCO Educational Book. We all know that testicular cancer is rare but highly curable malignancy that mainly affects young men. Multimodal advances in therapy have resulted in excellent cancer-specific survival, but testicular cancer survivors face significant long-term treatment-related toxicities, which affect their quality of life and require surveillance and management. With that, I'm very happy today to be joined by Dr. Aditya Bagrodia, a urologic oncologist, professor, and the GU disease team lead at UC San Diego Health System, and also the lead author of the recently published paper in the ASCO Educational Book titled Key Updates in Testicular Cancer, Optimizing Survivorship and Survival. And he's also the host of the world-renowned BackTable Urology Podcast. Dr. Bagrodia, I'm so happy that you're joining us today. Welcome.
Thanks, Pedro. Absolutely a pleasure to be here. Really appreciate the opportunity.
Absolutely. So just to say that our full disclosures are available in the transcript for this episode. Let's get things started. I'm really excited to talk about this. I'm biased. I do treat testicular cancer among the other GU malignancies. And so it's really, really important topic that we face every time, right? But fortunately for most of these patients, we're able to cure them. But it always comes up the question, what now? Scans, management, cardio-oncology, what survivorship programs we have in place. Are we addressing the different survivorship piece, psychology, fertility, etc.? So we'll try to capture all of that today. Aditya, congrats again. You did a fantastic job putting together the insights and thoughts and what we know today about this important topic. And so let's get focused specifically about what happens when patients get cured. So many of us in many centers were fortunate enough to have these survivorship programs together. But I find that sometimes from talking to colleagues, they're not exactly the same thing. And they don't mean the same thing to different people, to different institutions, right? So first things first, what do you tell a patient perhaps when they ask you, what can happen to me now that I'm done with treatment for testicular cancer, whether it's chemotherapy or just surgery or even radiation therapy? So what about the long term? What should I expect, doctor, that might happen to me in the long run?
Totally. I mean, I think that question's really front and center, Pedro, and really appreciate you all highlighting this topic. It was an absolute honor to work with true thought leaders, and the survivorship bit of it is front and center, in my opinion. It's really the focus. We, generally speaking, should be able to cure these young men, but it's the 10, 15, 20 years down the way that they're going to largely contend with. The conversation really begins at diagnosis, pre-education. Fortunately, the bulk of patients that present are those with stage 1 disease. And even very basic things like before orchiectomy, talking about a prosthetic. We know that can impact body image and self-esteem. Whether or not they decide to receive it or not, actually just being offered a prosthetic is important. And this is something, for any urologist, it's kind of critical. 2, discussing fertility elements to this, taking your time to examine the contralateral testicle, ask about fertility problems, issues, concerns, offer sperm banking, even in the context of a completely normal contralateral testicle. I think these things are quite important. So if it's somebody with stage 1 disease, without going too far down, discussing adjuvant therapy and so forth, I will start the conversation with, the testes do largely 2 things. They make testosterone and they make sperm. By and large, patients are going to be able to have acceptable levels of testosterone, adequate sperm parameters to maintain kind of a normal gonadal state and to naturally conceive, should that be something they're interested in. However, there's still going to be, depending on what resource you look at, somewhere in the order of 10 to 30% that are going to have issues. Where I think for the stage 1 patients, it's really incumbent upon us is actually to not wait for them to discuss their concerns, particularly with testosterone, which many times can be a little bit vague, but to proactively ask about it every time. Libido, erectile quality, muscle mass maintenance, energy, fatigue. All of these are kind of associated symptoms of hypogonadism. But for a lot of kids, 18 to 20 years old, it's going to be something insidious that they don't think about. So for the stage 1 patients, it absolutely starts with gonadal function. If they are stage 2 getting surgery, I think the counseling really needs to center around a possibility for ejaculatory dysfunction. Now, for a chemotherapy naive, nerve sparing RPL&D, generally these days, we should be able to preserve ejaculatory function at high volume centers. But you still want to bring that up and again, kind of touch base on thinking about sperm banking and so forth before the operation, scars. Those are things I think worth talking about, small risk of ascites. Then I think the intensity of potential long-term adverse effects really ramps up when we're talking about systemic therapy, chemotherapy, and then there's of course some radiation therapy specific elements that come up. So for the chemotherapy bits of it, I really think this is going to be something that can be a complete multi-system affected intervention. So anxiety, depression, our group has actually shown using some population resources that even suicidality can be increased among patients that have been treated for germ cell tumor. Really from the top down, tinnitus, hearing changes, those are things that we need to ask about at every appointment. Neuropathy, sexual health that we kind of talked about, including ED, vertigo, dizziness, Raynaud's phenomenon. These are kind of more the symptoms that I think we need to inquire about every time. And what we do here, and I think at a lot of survivorship program, is use kind of a battery of validated instruments, germ cell tumor specific, platinum treated patient specific. So we use a combination of ERTC questions and PROMIS questions, which actually serves as like a review of systems for the patient. Also as a research element, we review that. And then depending on what might be going on, we can dig into that further, get them over to see our colleagues in audiology or psychology, et cetera. And then, of course, screening for the hypertension, hyperlipidemia, metabolic syndrome with basically you or myself or somebody kind of like our serving many times as the role of the PCP, just making sure we're checking out, CBC, CMP, et cetera, lipid parameters to screen for those kind of cardiac associated issues along with secondary malignancies.
So that's super comprehensive and thorough. Thank you so much. Actually, I love how you break it down in a simple way. 2 functions of the testis, produce testosterone. And then, the problem related to that is the hypogonadism. And then the second, as you mentioned, produce sperm. And of course, related to the fertility of issues with that. So let's start with the first one that you mentioned. So you do cite that in your paper, around 5-10% of men end up developing hypogonadism, maybe clinical when they present with symptoms, maybe subclinical. So I'm wondering for our audience, what is the kind of recommendations we would give for addressing that or kind of thinking of that? How often are you ordering those tests? And then when you're thinking about testosterone replacement therapy, is that something you do it immediately? Are there any guidelines into context? Like, how do you approach that?
So just a bit more on digging into it, even in terms of the questions to ask, do you have any decrease in sexual drive, any erectile dysfunction? Are your morning erections still taking place? Has the ejaculate volume changed? Physically, muscle mass, strength, have you been putting on weight? Have you noticed increase in body fat? And sometimes this is complicated because there's some anxiety that comes along with a cancer diagnosis when you're 20, 30 years old, multifactorial. Hair loss, hot flashes, irritability. Sometimes literally they'll say, my significant other partners notice that I'm really just a little bit labile. So I think, there's the symptoms and then checking usually kind of a gonadal panel, FSH, LH, free and total testosterone, sex hormone binding globulin. That's going to be typically pretty comprehensive. So if you've got symptoms plus some laboratory work, and ideally that pre-orchiectomy testosterone gives you some delta. If they started out at 800, 900, now they're 400, that might be a big change for them. And then when you talk about TRT recommendations, Pedro, yourself, myself, we're kind of lucky to be at academic centers and we've got men's health colleagues that are ultra experts. But at a high level, I would say that a lot of the TRT options center around fertility goals. Exogenous testosterone treats the low T, but it does suppress gonadal function, including spermatogenesis. So if that's not a priority, they can just get TRT. It should be done under the care of a urologist, a men's health, an endocrinologist, where you're checking liver chemistries and CBCs and a PSA and so forth. If they're interested in fertility preservation, then I would say engaging an endocrinologist, men's health expert is important. There's medications, even like HCG, Clomid, which works centrally and stimulate the gonadal axis. Niche scenarios where they might want standard TRT now, and then down the way, 5-7 years, they're thinking about coming off of that for fertility purposes. I think that's really where you want to have an expert involved, because there's quite a bit of nuance there and recovery of actual spermatogenesis and so forth. To kind of summarize, you got to ask about it. Checking it is not overly complicated. We do a baseline pre-org, and at least once annually, you can tag it in with the tumor marker, so it's not an extra blood draw. And if they have symptoms, of course, kind of develop, then we'll move that up in the evaluation.
Got it. And you also touch base on the fertility angle, which is truly important. And I'm just curious, is, a lot of times, many of us might see 1-2 patients a year, right? And we forget these protocols and what we got to do about that. And so I'm interested to hear your thoughts about when you think about fertility and how proactive you get. In other words, who do you refer for a fertility clinic, for a fertility preservation program? Do you all cases, despite getting through orchiectomy, or just the case you're going to consider chemotherapy at some point? What kind of selection, or it depends on the chemo? Like, how do you do that assessment about referral for preservation program that you might have available as USD?
Yeah, I mean, I feel really fortunate to sit on the NCCN Testis Cancer Guidelines. It's in there that fertility counseling should be discussed prior to orchiectomy. So 100% bring it up. If there are risk factors, undescended testicles, previous history of fertility concerns, atrophic contralateral testicle, anything on the ultrasound like microlithiasis on the contralateral testicle, you kind of want to get it there. And then again, there's kind of niche scenarios where you're really worried. Maybe get a semen analysis and it doesn't look that good. Arrange for the time of orchiectomy to have oncotesticular sperm extraction from the quote unquote normal testis parenchyma. I think you have to be kind of prepared to go that route and really make sure you're doing this completely comprehensively. So pre-orchiectomy, all patients, don't really push for it too hard if they've got a contralateral testicle or if they've had no issues having children. There's some costs associated with this. Sperm banking still isn't kind of covered, even in the context of men with cancer. If they've got risk factors, absolutely pre-orchiectomy. Pre-RPL&D, even though the rates of ejaculatory dysfunction at a high volume center should be low single digits, I'll still offer it. That'd be a real catastrophe if they were in that small proportion of patients, and now they're going to be reliant on things like intrauterine insemination, where it becomes quite expensive. Pre-chemo, everybody, that's basically a standard these days where it should be discussed. And it's kind of amazing currently, even if you don't have a accessible men's health fertility clinic, there are actually companies. I have no vested interest. Fellow is one such company where you can actually create an account, receive a FedEx semen analysis and cryopreservation kit, send it back in, and all CLIA certified. It's based out of California. The gentleman that runs it, it's a urologist and very, very bright guy. He's done a lot of great stuff for testis cancer. So even for patients that are kind of in extremis at the hospital, that kind of need to get going, like yesterday, we still discuss it. We've got some mechanisms in place to either have them take a semen analysis over to our Mount South clinic or send it off to Fellow, which I think is pretty cool. And that even extends out to some of our younger adolescent patients where going to a clinic and providing a sample might be tricky. So I think bringing it up every stage, anytime there's a intervention that might be offered, orchiectomy, chemo, surgery, radiation, it's kind of incumbent on us to discuss it.
Gotcha. That's super helpful. And you also touch base on another angle, which is the psychosocial angle around this. You mentioned suicidal rates, you mentioned anxiety, perhaps depression in some cases, as well as chronic fatigue, not necessarily just because of the low testosterone that you can get, but also from a psychological perspective. I'm curious, what do the recommendations look for that? Do these patients need to see social worker or a psychologist, or do they need to answer a screening test every time they come to see us? And then based on that, we kind of escalate, take the next steps according to that. Do they see a psychologist perhaps every so often? How should that be managed and addressed?
It's a excellent question. And again, these can be rather insidious symptoms where if you don't really dig in and inquire, they can be glossed over. I mean, how easy to say your markers look okay, your scans look okay, see in 6 months and keep it kind of brief. First off, I think bringing it up proactively and normalizing it, that this may be something that you experience. Many people do. You're not alone. There's nothing kind of wrong with you. I also think that this is an area where support groups can be incredibly useful. We host the Testicular Cancer Awareness Foundation support group here. They'll talk about chemo brain or just like a little bit of a adjustment disorder after their diagnosis. Support groups, I think, are critical. As I mentioned, we have a survivorship program that's led by a combination of our med-oncs, myself on the uro-onc side, as well as APPs, where we are systematically asking about essentially the whole litany of issues that may arise, including psychosocial anxiety, depression, suicidality. And we've got a nice kind of fast path into our cancer center support services for these young men to meet with a psychologist. If that isn't going to be sufficient, they can actually see a psychiatrist to discuss medications and so forth. I do think that we've got to screen for these because, as anticipated from diagnosis, those first 2 years, we see a rise. But even 10, 15 years out, we note compared to controls that there is an increased level of anxiety, depression, suicidality that might not just take place at that initial acute period of diagnosis and treatment.
Really well said. It was super important. So I guess if I were to put all this together with this really amazing advances in technology, we all know AI. Some of us might be more or less aware of biomarkers coming up, including microRNA, for example, and others. Like, as I think of all these potential long-term complications for these patients, look at the future, I guess. Can we use this as a way to de-escalate treatment where it's not really necessary, as a way to actually prevent some of these complications? Like, how do we see where we're heading as we manage testicular cancer, let's say within the next 5 or 10 years? Do you think there's something coming up that's going to be different from what we're doing things today?
Totally. I mean, I think it's as exciting as a time as there's ever been, maybe notwithstanding circa 1970s when platinum was discovered. So microRNAs, which you mentioned, there's a new candidate biomarker, microRNA 371. We are super excited here at UCSD. We actually have it CLIA certified, available in our lab, and are ordering these tests for patients kind of their acute stage, stage 1 in surveillance, stage 2 post-RPLND, receiving chemotherapy. And essentially, this is a universal germ cell tumor specific biomarker, except for teratoma, suffice it to say, 90% sensitive and specific. And I think it's going to change the way that we diagnose and manage patients. Pre-orchiectomy, that's pretty straightforward. Post-orchiectomy, maybe we can really decrease the number of CT scans that are done. Maybe we can identify those patients that basically have occult disease where we can intervene early, either with RPLND or single cycle chemo. Post-RPLND, identify the patients who are at higher risk of relapse that may benefit from some adjuvant therapy. In the advanced setting, look at marker decline for patients in addition to standard tumor markers. Can we modulate their systemic therapy? So the international interest is largely on modifying things. There's really cool clinical trials that we have for stage 1 patients that treatment would be prescribed based on a post-orchiectomy microRNA. I think the microRNAs are really exciting. Teratoma remains an outstanding question. I think this is where maybe ctDNA, perhaps some radiomics and advanced imaging processing, incorporating AI may allow us to safely avoid a lot of these post-chemo RPLNDs. And then identification using SNPs and so forth of who might be most susceptible to some of the cardiac toxicity, ototoxicity, and personalizing things in that way as well.
Super exciting, right? What's about to come. And I agree with you. I think it's going to change dramatically how we manage this disease. This has been a pleasure sitting down with you. I guess before letting you go, anything else you'd like to add before we wrap it up?
Yeah, first off, again, just want to thank you and ASCO for the opportunity. And it's easy enough to, I think, approach a patient with the testicular germ cell tumor as this is an easy case. We're just going to do whatever we've done, go to the guidelines that says do X, Y, or Z. But there's so much more nuance to it than that. Getting it done perfectly, I think, is mandatory. Whatever we do is an impact them for the next 50, 60, 70 years of their life. And I found the germ cell tumor community, people are really passionate about it. If you're ever uncertain, there's experts throughout the country, internationally. Ask somebody before you do something that you can't undo. I think we owe it to them to get it perfect so that we can really maximize the survivorship and the survival like we've been talking about.
Aditya, thanks for sharing again your fantastic insights with us on this podcast.
All right, Pedro, fantastic. Appreciate the opportunity.
And also thank you to our listeners for your time today. I actually encourage you to check out Dr. Bagrodia's article in the 2025 ASCO Educational Book. We will post a link to the paper in the show notes. Remember, it's free access online, and you can actually download it as well as form as a PDF. You can also find on the website a wealth of other great papers from the educational book on key advances and novel approaches that are shaping modern oncology. So with that, thank you, everyone. Thank you, Aditya, one more time to join us. Thank you. Have a good day.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.